Okay, Assalamu alaikum everyone. I hope everyone is doing good. Today we're gonna have our weekly meeting and Dr. Sarah will lead the meeting. Thank you so much, Sarah, when you're ready.
Thank you, Dr. Nadir. I'm just wondering if the Orange team are ready for their topic on gastroenterology. I'm presenting today instead of Dr. Mazen, and I would be happy to present my presentation about leadership. There will be a presentation about gastroenterology as well. And then Dr. Iman and Dr. Selma will present their poster for us, and we'll see what they knew about the project afterwards. So this is just an idea about the presentation of today. So my name is Sarah Ahmed. Just introducing myself. I am a Telegeriatric fellowship. I am learning a lot from this fellowship actually, and I'm enjoying being part of all this great work. So we'll wait for like 1-2 minutes for people to join maybe before starting.
Sounds good. Thank you so much. So in the meantime, I want to share with you some news. So if you go to the app and the first page, I think the first, we have new information from Washington, D.C. and it seems like they have approved some residency for international medical graduates and exceptional license for international graduates. So the only thing is you need to be there, I think, resident for 1 year. But at least we have some options there. We can discuss this more. But if you look at the app in the main section there, you will see some information about Washington State license provided for international graduates.
Right?
Thank you. What's that?
That's Washington State, not Washington, D.C.
Washington State, yes, correct.
Yeah, okay.
Yeah.
That's great news.
Yes, that's a good one. Thank you. So I think we can go start, and then anyone will join us later. They can review the recording. Thank you.
Thank you, Dr. Nader. Such a good news for the applicants, RMG applicants. So is Dr. Abdelhadi or Dr. Tamadur is here to present their gastroenterology presentation? I am seeing the name. There is none here yet. So I will go ahead and start my presentation about leadership. Sorry, just my computer is okay. Screen. So do you see my screen?
Yeah.
No.
I'm sorry for that, sorry. Do you see it now?
No.
No.
Oh, shit. Sorry. A moment.
Hello, everyone. Assalamu alaikum.
So, how are you?
Sorry, I will open the other computer and then just it's gonna be 2 minutes.
In the meantime, while the Sarah is working on the presentation, any updates as far as interviews or good news from any one of you guys? And it's fine for residency. Or any updates as far as the products going? Any new ideas? Anything anyone of you wants to share?
I see Dr. Tamador is here. I'm sorry, Dr. Ala. So if Tamador is ready, we can start with Tamador.
Okay, if the mother is here, yeah, that's great. Then if the mother is ready, you can start the gastroenterology presentation.
You can go ahead, Dr. Ala. She had a question for Dr. Nader. Sorry for that.
No, I don't have any questions. Just we're waiting for the match results so far.
Yeah.
We end with the interviews and just I have only one questions regarding the second look. What's mean by this and like second look interview and should we like rank this program higher than others or it's one matter of fact?
So anyone can jump in and can answer this question, but in the past when they had interviews in person, they will invite you, you will tour the institution or the hospital and then they will let you talk to the residents. So you will have a good idea about the program and then you will work on your list, but some of the applicants will ask for another round just to verify things or to look at more hospitals or some. So they will have another visit to the program when they have a chance. If that's the case nowadays, I'm not sure if they can do it virtually or how, but I think that what happened in the past. If anyone has other information, please go ahead. Tomato, when you are ready, and you can start with inhabitants.
Assalamu alaikum. Hello, everyone. Me and Dr. Abdelhadi, we're supposed to present gastroenterology. I will start from the middle. And when he joins, he will start from the beginning. So I will start by irritable bowel syndrome.
Good.
Okay. Let me share the screen. You see my screen?
Yes.
So about gastroenterology, there are common diseases and disorders, especially in elderly. I will start from irritable bowel syndrome, and then, as I said, Dr. Abdelhadi will join and do the first slides. So irritable bowel syndrome, it is a functional GI disorder. It can be remission, there is a remission and exacerbation, and the symptom usually is like abdominal pain, bloating, constipation, diarrhea, or both. The patient can have constipation sometimes and sometimes diarrhea, or like it is not fixed like one symptom. And diagnosis usually by exclusion. If we have a patient come with this symptom, we have to exclude the other diseases like intestinal ischemia, diverticulosis, colon cancer, or inflammatory bowel disease. So the workup for this syndrome, it can start by exclusion. So we have to exclude other disorders. We will start by colonoscopy. Although it is invasive, I feel it is invasive to do colonoscopy, but they start by colonoscopy to exclude the structural abnormality of the colon, the diverticulosis, the colon cancer, and other GI problem, the structural one. So we do the colonoscopy, and then if we didn't have, we reach to diagnosis. So we go to CT scan of the abdomen, and small bowel series may also be useful. So if the history, physical exam, and lab or imaging study are negative, then we can reach to the diagnosis of irritable bowel syndrome. And there is subtypes or subcategory. Irritable bowel syndrome with constipation, irritable bowel syndrome with diarrhea, or both constipation and diarrhea. And the treatment will be symptomatic. Like we go, if the patient has diarrhea, we give anti-diarrheal. If there is constipation, we give fiber supplements, and also reassurance, because it is functional disorder. Serotonin, there is something with serotonin. They didn't give, not every physician can prescribe this medicine because it can lead to ischemia. Should be used with caution, especially in older patients, and access is strictly limited to physicians enrolled in the premises prescribing program. So not everyone can do this, or physician can prescribe this medicine. So basically, the treatment will be reassurance, antispasmodic for the pain, for the abdominal pain, and antidiarrheal if the patient have diarrhea, and fiber supplement for constipation. The other diseases that I will cover, occult GI bleeding. So first of all, we have the thing that we worried about, the colorectal cancer. We have to exclude this first. If the patient come with occult GI bleeding, first of all, we have to think about colorectal cancer because it is a leading concern. And the other causes, esophagitis, peptic ulcers, esophageal and gastric malignancy. So all malignancy start from esophagus, gastric, colon. And then we have intestinal and colonic angiodysplasia. I will come for this and explain what is angiodysplasia. And we have benign colon polyps and inflammatory bowel disease and hemorrhoids. So the patient, we will start by, in the stool, we have the occult blood. So we go for from there, the FOB test when it is positive. Then we go for colonoscopy. Why? Because we want to exclude the malignancy and serious condition. So you have the patient having FOB, fecal occult blood test positive, then you want to do colonoscopy. So especially in elderly, in older patient, you do colonoscopy because you want to exclude the serious condition like colon cancer. And so in older patient at risk of colon cancer, the presence of proximal lesion should not preclude evaluation of the colon. If you see something in the proximal, you also need to do the colonoscopy. So if colonoscopy is negative, what we can do, we do upper endoscopy. So positive result likely if upper GI disease present. So we do colonoscopy. If it is negative, we go for upper endoscopy. If source of bleeding is still unidentified, we consider video capsule endoscopy. The other topic that, or the other thing that can cause occult blood bleeding, the colonoscopy, colonic angiodysplasia, sorry. The angiodysplasia, what is angiodysplasia? It is the AV malformation, sorry. The atriovenous malformation. It is the same synonymous to angiodysplasia. It is something abnormal in the vessels. And this condition occurs most often in cecum and ascending colon, where they may cause bleeding, especially in patients more than 60 years. And throughout, this can happen in any part of the GI tract, but specifically in maybe most common in cecum and ascending colon. And maybe multiple, like you find some here and other in different parts. Maybe asymptomatic, the patient does not have any symptom. And just when you do the fecal FOB test, you find it positive. And the cause may be angiodysplasia. Okay. Colonic angiodysplasia, usually diagnosed during colonoscopy. So diagnosis can happen maybe during screening. You screen the patient, you'll find, accidentally you find the angiodysplasia. And it is about 5 to 10 millimeter cherry red blood vessels. And it is something like radiated to the, from a central vascular core. There is central and there is radiation from that part. And so you find it in the colonoscopy, you do angiography to localize the active, if the patient having the positive test. You do the angiography. If incidental findings should not be treated. Incidental, yeah. Maybe patient asymptomatic, there is nothing, you will not do any treatment. But if the patient having has active bleeding, should be treated. Endoscopic ablation. So the treatment will be if the patient having has acute bleeding can be successful controlled by endoscopic ablation. But this method can lead to rebleeding. Angiography, when you do angiography, you can do embolization or infusion of vasopressin. This can be a treatment for the angiodysplasia. And surgical resection. Definitive for lesion clearly identified as the source of bleeding. So you know the source of bleeding is exactly where you have the angiodysplasia. So you can do surgical resection for this part of vessels that causing the angiodysplasia. Let us go for colonic ischemia. The patient presents with abdominal pain, lower GI bleeding, and treatment usually supportive. Even with treatment, colonic strictures may, so the complication of ischemia can be strictures to the colon. And development of peritoneal sign call for resection. Is a patient having a peritoneal sign? This mandate the surgical resection. Okay, now we go for Clostridium difficile infection. And this is common in hospitalized patients taking antibiotic and often precipitate in hospital and long-term care facility. This is the precipitating factor. This high mortality present with, what is the presentation? It will be like watery diarrhea, crampy, abdominal pain, fever, abdominal tenderness, and distension, elevated WBC. So you have the patient hospitalized for a long time taking antibiotic, and you notice there is watery diarrhea, fever, high WBC. So you put in your mind, maybe it is Clostridium difficile infection. Consider when acute abdominal distension also, the patient having abdominal distension, you have to consider the Clostridium difficile. Antibiotic treatment. So the treatment for this condition is antibiotic. You give antibiotic for 10 to 14 days. The antibiotic option will be oral metronidazole, 250 every 6 hours, and it is effective in 85% of cases. And if the patient severely ill and there is ileus megacolon, you give IV metronidazole. And the third option, oral vancomycin, also highly effective. There is sometimes there is a relapse for the Clostridium difficile infection, require repeat and treatment. You will repeat the antibiotic again, metronidazole, vancomycin, or vancomycin. So you have to make sure that the patient is negative from this. You repeat the test, Clostridium difficile test. Acute colonic pseudo obstruction. What is pseudo obstruction? There is no mechanical obstruction. It is like functional. Acute massive dilation of the colon without evidence of mechanical obstruction. So this needs urgent colonoscopy. This assists with the diagnosis, allow placement of decompression colonic tube. And the treatment often lead to rapid resolution. You give parenteral fluid, supportive measure, discontinuation of necrotic, IV neostigmine. Another condition is colorectal polyps, typically asymptomatic. The patient having the polyp, there is nothing, but may bleed. Classified as neoplastic, we have the adenomatous polyp or the hyperplastic, the non-neoplastic. So we have two types of polyps. And if you discover this while you are doing colonoscopy, they recommend to take this polyp. Removal of adenomas significantly decrease the colorectal cancer. Adenoma are most often detected by colon cancer screening, primary sigmoidoscopy and not FOB. So they usually discover the polyp during the colonoscopy. Colorectal cancer. It is the US third leading cause of cancer. This is why it is very important. And the second leading cause of cancer deaths. The risk increased dramatically with age. This is why they do a screening for colorectal cancer. Perform colonoscopy in all cases of hematochezis, occult GI bleeding, eye deficiency, anemia, or melanoma after a negative upper endoscopy. So we do colonoscopy also, apart from the screening. If the patient having hematochezia, occult GI bleeding, this is indication for colonoscopy. Iron deficiency anemia, melanoma after a negative upper endoscopy. So we do colonoscopy in all these cases. Symptoms such as abdominal pain, altered bowel habit, pencil thin Stools are less predictive of colorectal cancer, but require thorough investigation starting with colonoscopy. So we have to be careful about colonoscopy and to discover the disease early is better. The surveillance colonoscopy, recommended interval. So 3 years for most patients with adenoma. So if the patient having adenoma, every 3 years, you will do colonoscopy. 5 years if initial screening is negative, or if only a small tubular adenoma is found. And every 1 year, you do colonoscopy after removal of a large villus adenoma or for a patient with colorectal cancer. I don't know if Dr. Abdelhadi is here, or we can go to the case.
So if Dr. Abdelhadi is not here, so I think we will get him later and I will present instead of him. Thank you, Tamadur. Very good presentation. I'm not sure whether we should go for a question now or maybe wait for Dr. Abdelhadi. Thank you, Tamadur.
If he's not here, we can continue and do the cases.
Okay, perfect. But that not depends on his introduction, the cases?
No.
Okay, go ahead. Thank you.
So in summary, although the physiological change of aging can affect GI function, most GI symptoms signs are due to pathological conditions. Many of the medication used by older people, so the medication, we know that the older patients, they are taking multiple medications. So, and the medication having side effect. We have to be careful about that. The risk of colorectal cancer increased dramatically with age, and symptoms require thorough investigation beginning with colonoscopy. Let us begin with case 1. 75-year-old woman is brought to the ED because of right lower quadrant pain that has gradually increasing in intensity over 36 hours with associated nausea and diarrhea. So the patient, 75-year-old, brought to the emergency with right lower quadrant pain that has gradually increased intensity over 36 with nausea and diarrhea. She reports no relieving or exacerbating factor and is otherwise healthy. On examination, she appeared uncomfortable. Temperature is 98.4 Fahrenheit. Blood pressure is 140/85. Pulse is 94. Respiratory rate is 16 per minute. And she has right lower quadrant abdominal tenderness with no girding or rebound. Bowel sounds are depressed. CBC is normal. Urine analysis demonstrated by urea. Plain radiography of the abdomen demonstrates non-specific changes. Okay. Which of the following is the best next step? We do barium enema, urine culture, CT of the abdomen and pelvis. Which one you will start with, or the best next step? Urgent signal, endoscopy, or what else? I cannot see the chat. Anyone write anything? Sarah, you see any answer?
Yeah, there is Amna Al-Khadir C, Muhammad Tijani C, and I said C. I agree with it.
Yeah,
okay. C. Yeah, so they all agreed on C.
Yes, we start with the CT scan. We want to know what is going on. Yeah, we start with CT. It's the correct answer. Okay, 74-year-old man undergoes initial screening colonoscopy. He is asymptomatic and has no family history of colon cancer. A fecal occult blood test is negative. 3 centimeter adenomatous polyp without atavia is removed via polypectomy. The colonoscopy is otherwise normal. So the patient, 74-year-old, she she having like the regular screening colonoscopy, they discovered there is adenomatous polyp, they remove it. So when should colonoscopy be repeated? 6 months, 1 year, 2 years, 3 years, 5 years. Because I don't see the chat. You're muted.
So my answer is E. Akhidir is saying A. Mazin is saying D. Like between, like D is 3 years. I'm saying 6 months. I'm saying 5 years because I think it's low risk, the adenomatous polyp, and it was removed. So I'm not sure. Afrah is saying D, 3 years. Hiba Abu Alama is saying E. Muhammad Tijani is with 3 years. Ala Abdul Samad is saying 3 years. Yeah.
Okay, it is 3 years. Let us go for the slide screening. Surveillance. Yes. So 3 years for most patients with adenomas. 5 years if initial screening is negative or if only small tubular adenoma is found. So it is 3 years. Okay, let us go for the third case. 70-year-old man comes to the office because he has diarrhea with associated crampy abdominal pain and low-grade fever. So diarrhea, abdominal pain, and fever. The diarrhea began 3 days earlier. He is passing up to 5 watery, non-bloody bowel movement daily. His history includes venous insufficiency, and he was recently treated with 7-day course of cephalexin for lower extremity cellulitis. On examination, he does not look ill, and vital signs are normal. Abdominal examination demonstrates mild, non-specific diffuse tenderness without girding or rebound. Bowel sounds are present. Laboratory results are normal, except for a WBC count of 11,000. Abdominal radiography demonstrates a non-specific GADS pattern. Enzyme immunoassay detect Clostridium difficile toxin A. The patient improved with 10, so they say the diagnosis is Clostridium difficile. The patient improved with 10-day course of oral metronidazole, but diarrhea recurs within 1 week. An enzyme immunoassay again detects Clostridium difficile toxin A. The question is, which of the following should be prescribed next? Rifampicin and metronidazole, vancomycin, cholestyramine, Saccharomyces boulardii. So what you will give to the patient with recurrent or relapsing Clostridium difficile?
They're agreeing on C, vancomycin. Tahani, Avinash, Ala, Amna, Afrah, Mazin, Hiba, they're all like saying C. That's vancomycin.
Okay, let us see the answer. It is metronidazole. I don't know, but they say you can give either of them. I don't know. I'm not sure about this question. Because they say you can give metronidazole, you can give vancomycin, and also the rifampicin and metronidazole. But maybe they use metronidazole because they say it is effective in 85% of patients. So it is the common medicine for this condition.
I think they updated now. Sorry for jumping in. I think they updated now. They say it's vancomycin whenever you have a recurrent for Clostridium difficile, and you use IV metronidazole. I think if you have a megacolon is appearing. And please correct me. Is anyone knowing the same information as I know?
Question is, does this consider reinfection because it's only 1 week and the positiveness of the stool, because sometimes it stays positive for a while. I know, but I'm not sure.
Yeah, for the megacolon, they say, yeah, give IV metronidazole.
Yes, and for the, if it's just recurrent, you give vancomycin. And that's, I think, in, yeah. Thank you, Tamadar.
So I come to the end of my presentation.
Thank you very much, Mother. Nice presentation. I will let Dr. Nader.
Thank you so much, Dr. Mother. This is really great, excellent presentation, concise, and I think we touched on, it's a big topic, so we touched on some important aspects or points. Regarding the last question, I think the guideline might be different from previously. So I will tell you what I think, and then you can follow that or get some updates. The infectious disease team might have a different picture. So what we do is when the patient comes first time, we give the metronidazole. If it's a second time or if it's failed, then we can try the oral vancomycin. We may use the IV, as you mentioned, with some conditions like the colon, or sometimes we use the IV when we expect that the rate of the diarrhea, the inflammation is so fast or active that the blood will carry the vancomycin to the area where there is inflammation and the infection is there, very active. So usually we use the vanco as oral because it goes to the GI and kill the bacteria there. But if they have the frequency and active disease, then we may use the IV. But in general, we go use the oral. There is a new medication, Difficile. It's a new one, also can be used. It's kind of expensive. Some insurance will cover for that, but they need to make sure that you tried and failed, let's say, metronidazole or the oral vanco, and then it will be the second option or the second line because of the cost. Thank you.
Thank you, Dr.
Thank you, Commander. Does anyone have any questions? Okay, I do not see anyone raising his hand. I'm not sure what Dr. Hadi is going to be presenting, but I think one of the main gastroenterological problem in elderly is constipation. And I think proper management of constipation is very important, as it can cause like agitation, delirium, and it might cause UTIs as well on some of the patients. So to affect their mobility, their cognitive function, and all that. Just highlighting this. So is Dr. Abdelhadi here? I do not see his name on the attendance. Waiting for Dr. Abdelhadi to come, I'm gonna start my presentation about leadership skill. Thank you, Tomadur. You see my screen, everyone?
Yes.
Yes. I got a new Apple Mac that I obviously I don't know how to use it, but now it's okay. So I am presenting today a presentation about leadership skills. Again, I am Sarah Ahmed for the people who just came late. I am a research fellow at Michigan State University, Telegeriatric Fellowship. So leadership skills. So this presentation is going to be more like interactive presentation. So I would appreciate it if you participate and help us to get like a productive conversation and efficient. That will help us to have an idea about leadership. So let us stop for like seconds and let us think about a leader in our life. A leader that the first one came to our mind, and think about the qualities we think that made him an extraordinary leader. Either it's a parent or a boss, a teacher, or even a political elect. So is anyone want to give us his give us some idea about a leader in his life or someone he came across? Anyone?
Yes, I can jump. So I would say, for me as a leader, I could say my mom. I learned a lot from her that you need to be patient to have to see progress in your life. And other than my mother is Nelson Mandela. Is when we all know that South Africa they have a conflict in tribes and they never come to one word, and he was able to reunion, and he was the first African president over there, and he was very popular between all the tribes. So I love his philosophy, I love his approach. So yeah, this is my examples, and thank you.
Thank you, I appreciate that, Hiba. So just we'll go a little bit in details, if you don't mind, that about your mom. What do you think made her, you think, a successful, respected leader? Like, what qualities do you think she had?
She's a very determined person. Whenever she wants to achieve something, whatever time it takes, she make it happen. And also she is able to adapt in an environment that is not her home country, and without any support system, and being taken care of an ill husband for 10 years, and being happy about doing that. It just give me a message that whenever you love something and you're doing it in love, you will be happy even if you're struggling during this period.
Okay, so she was determined, hardworking, flexible, and loving what she was doing. So this is the main qualities, you think? Yes. Okay, perfect. Thank you, Hiba. That was very helpful. Anyone else want to share his ideas? I can't see the people who are raising their hands, so just feel free. I can't see anyone raising his hand, so I will actually share my experience. It's a recent experience, actually, and it was with one of the fellows, actually, in this fellowship, Dr. Ala Abdel Samad. I was really honored to work with her in our project about pain management in nursing home residents. I was really, really amazed by her ability and her qualities of leadership. She is very organized person. She was giving us very clear, she's good communicator, giving us very clear, open communication about our tasks. She is able to delegate tasks very well. And she herself was able to do the task. So she was leading by example to me. And I think it was a great experience. I have learned a lot from her. It was actually the first time for me to work in a research group. So it was, we learned a lot. And I think all of the group was like, we're working hard to kind of reach our goals. and do the project. So thank you, Ala. You were a great reader.
Thank you, Sam, actually, for sharing your words, and it will give me, more support and to continue and to start a new project as well. And I was so happy to work with all the fellows. They are very supporting, and yes, we work together as a team. I'm so happy for all, and wish you all success. Thank you.
Thank you. That's give us an idea that as a healthcare professionals, actually, we do a lot of leadership, and it's a part of our daily job to be a leader of our team, to be leading our clinic, our service, and all that. So we should all have kind of ability or a skill of being a good leader at some point in our life. I am just going to the next slide. I got this quote from Martin Luther King, one of the great leaders in the history, saying, "A genuine leader is not a searcher, but molder of consensus." So as what he say, that leaders, good leaders, successful leaders should be able to reach the consensus on their team rather than searching for it. It's something that you do, not you wait for other people to do. It's actually a great quotation.
Sarah, are you sharing your screen?
Yes.
We cannot see it.
Okay. So I will
No,
stop.
it's there.
Oh, we can see.
We can see.
we see
We can
it.
see.
Can see it.
Yeah. How is it?
Really?
How is it? How is
Sorry?
it?
Yeah, we can see it.
Okay, perfect.
Can I share a leader before we go on?
Yeah, of course. Go ahead.
Okay, I wanted to share Dr. Nader as a leader, and I wanted to say that, there are certain traits a leader needs. Like, one thing is availability. Like, throughout the season, Dr. Nader has always been available in terms of if you want to contact him. He's been really supportive for all of us in terms of like being invested in our careers. And he's an IMG himself, but he is doing this for us to kind of, see our success in the future. So I think that, availability, being supportive, being understanding, and giving back to people that can benefit from your own success are important traits of a leader. So that's it. Thank you.
Thank you very much, Kruba. Dr. Nader will be definitely mentioned in this presentation.
Thank you.
Thank you. So here is leader, L-E-A-D-E-R. It stands for L, listens. These are like traits that definitely a great leader would have. E for expecting the best. Being optimistic is one of the great traits to be a successful leader, to be an achiever, and determined, as Hiba said earlier. Encouragement and giving the spirit to your team is very important factor to success of a team. And then the last but not the least is respect. So keeping respect to all the team members, regardless their position on the team, is one of the key factors for success and for a successful leader. So leadership definition, this is what I found in the literature, that leadership is the quality of behavior of the individuals whereby they guide people or their activities in organized effort. Other definition is leadership. It's a process of influencing and supporting others to work enthusiastically toward achieving objectives. So leadership is not like a position, or it's not like a one-time thing. It's a process, and it's mainly through influencing and supporting others to achieve the goal. Here is another quotation from John Adams, that if your actions inspire others to dream more, learn more, do more, and become more, you are a leader. So the main kind of job of a leader is to inspire others to be better people through learning more and dreaming more and becoming better people. So one of the quotation as well that inspired me, that good leaders actually are made, not born. So all of us have this idea that there's like a specific personal trait that someone should have to be a great leader or a successful leader, while it's actually not right. The right is through the hard work and the continuous hard work and self-study, self-awareness and other things, you would be able to develop and be a successful leader. Good leaders actually develop through a never-ending process of self-study, education, training, and experience. To inspire your workers into higher level of teamwork, there are certain things you must be, know, and do, and we are going to talk about this in details later. Leaders carry out the process of leadership. As we said earlier, it's a process, it's not like a position, through applying their attributes such as beliefs, values, ethics, characters, but most importantly, their knowledge and skills. So it's not only their beliefs and values and ethics and character, it needs to be supported definitely by knowledge and skills. So to become a leader, you need to get out of your comfort zone. No one, like all the time, going out your comfort zone is the only thing that make you better, make you develop and improve. It's not an easy thing to be a leader. It's full of challenges, but you only learn it through doing it. You have also to do your homework, like study great leaders in the history, people who inspire you, people whom you feel like you want to be like them if you are a leader, and then take the advice from the people you have an access to, your leaders, the ones you think that they are successful and good leaders, and research and gather resources. Definitely there is a lot of good courses and information about being a leader. It will help a lot for someone who's starting their first leadership, or even if you want to be better and better. Encourage yourself that you have the confidence that you're gonna be able to do this. Optimism is an important factor when you are leading a team that's you're gonna be successful. The most important thing is you create a plan. You know what you're gonna do and when and how. And the last but not least, again, is to protect your craft. One of the important things about leadership is that you make your team feel safe, that you are protecting them, that you are on their back, and you're gonna support them and provide them for all the things they need. So we're gonna talk about the be, know, do concept. It's a concept that adapted from the official Army leadership manual. And it's say like be stand for be a professional example, in a way that your knowledge of the project that you are working on, you're on doing tasks, your punctuality, your behavior toward work and all that, be the example for your team. The second thing is be loyal to the organization. Be selfless at your work, so that you will show that your team that you're loyal to the organization, you're loyal to the project and loyal for them. The third one is be a professional who possesses good character traits. Definitely, if you are if you come late, or if you're incompetent, or you lie about stuff, you're not reflecting a good example of a leader, and definitely this will reflect back into the work, the confidence of your team on you, all that will be affected. So good character traits of a good leader will be like honesty, definitely is a very important one, competence, commitment to the project. Integrity is an important factor, courage, straightforwardness, and imagination. All are the traits for good leaders. Let us come to know. One of the most important things about leadership, if you want to be a successful leadership, I've read a quotation saying that if you want to be a good leader, you have to invest about 40% of your time on knowing and improving yourself. Self-awareness is a very important thing, that knowing your limitation, knowing your strong point, your weak points, that's a key to go to the next step on leadership. The second thing is, you know the human nature. You know that your team is human, they're humans, and they have their ups and downs. You understand their emotions, the social situation that they're going through. Through giving them the support they need, the compassion, you actually make them feel supported, and they will definitely give their best and try to improve and try to work hardly to kind of overcome these struggles they're going through. The third one is know your job. Through continuous learning, development, like depending on the job, like for us as a doctors, definitely we have to know our patients. For example, we need to know what's the new in medicine. You need to know how to treat patients. Definitely knowledge is important. Having the knowledge and the skills, that is important to fulfill the job. The third thing is know your organization. Understand their mission, their rules, their like environment, and all that would definitely help yourself and your team to work toward your goal. The third one is do. And here is the area about like doing the job actually, rather than after you prepare yourself, you prepare your team, then we come to the we are implementing the leadership. You provide actually direction to your team through planning, through time management, through giving the directions and all that. Then implementing what you all reach, like if you put the plan and all that, you should be the one who is implementing and making sure the process is going well and giving the feedback and trying to improve. The last one is motivate. So giving your team the spirit, the like courage to continue working and all that. It's the leader responsibility. Then what makes a great leader? It's an open question for anyone who wants to participate. What do you think makes a great leader? Again, like, yeah. Is anyone want to say something?
Yes, I think you put yourself in the people that you lead, and you can figure out how you want your leader to treat you or to deal with you.
Okay, so you think that like to treat your team well, like the way you like to be treated?
Yes, exactly.
Okay, definitely. Totally agree with you. Any other ideas?
I think someone who leads by example will be a great leader, because this way everybody else will know what they should do or what's expected from them.
Yeah, like passively they would follow them because they like him and they want to be like him, right? Okay, thank you.
And also ask your people that you lead about feedback.
Yeah, great.
Like what about the work that you give to them? So ask for feedback.
Yeah, definitely feedback is an important factor, but the problem would be because you are their boss or their leader, they might not give you honest feedback. They might be afraid that might affect their progress, or what do you think?
A great listener, someone can listen to you, address your problems, and motivate you.
Yeah, listens. Yeah, good leader is a good listener, or a good listener is a good leader. Okay, thank you everyone for your input. That was great. I see a message here. If someone, what are the common leadership styles? It's coming in the presentation. Okay, so this is another quotation from John Maxwell saying that a good leader is a person who takes a little more than his share of the blame and a little less than his share of the credit. This is an important part of being a leader, that you know that you're going to sacrifice you're going to take most of the blame, and then you're going to get less credit about the good things you do by giving the credit actually to the team. We see a lot of examples where like leaders, they take the credit of success, and when it comes to failure, they actually blame their team for not being cooperative or not working hard. So this is actually give you kind of an idea about the good leader who's actually ready to sacrifice and take the blame while give the credit to others. Go to the next slide. So this is some qualities of a good leader. I found there's load of the things that I didn't write, but this is give you some idea. A good leader would have a vision about what he is doing, definitely, and he would be someone who had an open imagination and ideas about what he's looking forward to in the organization or for the project. He is a decisive person. Definitely, if you are not a decisive person, you would not be a good leader. You're taking the risks, because someone who doesn't take risk, it's not someone who's gonna go success or make a huge difference. Motivate others. Again, motivation is it's an important key of leadership, and has ability to build diverse teams, and possess self-knowledge and display integrity. Integrity is an important factor as well, and pursue a lifelong learning. It's a lifelong process, being a leader and a successful leader. It's not like one job and you're just there and then you're the best leader ever. You are actually progressing from a position to another higher position. Communication is a key all the time for successful teamwork and helping others to succeed. Actually, the main job of a leader to help others to progress and be another leaders. Leader responsibilities. So actually, a leader is the one who knows the way and goes the way and shows the way. This is another quotation from John Maxwell. So the leader responsibilities is to delegate tasks and provide support and provide feedback, definitely constructive feedback, where you prepare the environment for your colleague or your team member to give them the feedback and telling them what they should do to improve, or maybe explore with them the problem and try to find a solution with them. It's always better, rather than giving advice, direct advice to someone to tell them what to do, is actually to start an open discussion and see what's the problem and see what they are able and thinking to do better in the future. And the positive feedback is good as well. It gives the motivation to team members. So whenever there is someone who's doing extra work, who working hard, it's definitely important to give them the good feedback. Individuals development, you have to work in your development of your team. Making change. You'll never be a successful leader if you are actually not making a significant change from what it used to be. So making big changes are important. Influence and motivate people, as we said, and time management. Time management is a key factor of success. We talked about that last week. Dr. Tijani, I think he had a great presentation about that. And then team leader actually is a connection between team members. You have to get to that position where everyone trusts you. And even if there is a conflict or something, you are the one you should find the ground for all the workers with diversity and all that. You manage that, you will be to make the team work efficiently and to make the environment healthy and people are cooperative with each other. Definitely, this is all the criteria of a leader to be successful. And then communication, clear, open communication is very important, that you communicate your plans, you communicate your feedback, you communicate the tasks, and all that is an important. So those are the leader responsibilities I came across. Here we we're speaking about leadership styles. So there are many, and it depends on the type of the leader himself, what he thinks that his team is going to follow him for like. So the first type is coaching, and this one is mainly around like developing others. And I think we are in this example, like what Dr. Nader is doing is actually coaching us and watching us developing. Other type is visionary. Visionary leaders have a vision of where a company and organization should be. So those people are like, they have a vision to change, that fully change the organization, and they are working toward that. Then there is servant leadership, where they those are believing people first. So these are like kind of, for example, they should be in the government, where they're actually there in their position, leader position, to help others. Then there is the autocratic, that the boss and manager make all the decisions. So actually the team member does not participate in making decisions. They're actually only delegating. They just receive the task and they have to do it. Then there is a laissez-faire. I'm not sure if I'm saying it right, but it's a hands-off side of leadership. That's like the leader is just keeping an eye. It's actually, he doesn't give you direct like advices or giving you the plans. Actually, you keep the team to kind of come with ideas and do them, and you follow them, just like, and give them feedback or whatever. It's hands-off. Like the leader is not directly giving the instructions of his team. Then there is a bureaucratic. It's a rule-based leadership style, where like there is a rules, like say like government, there is rules and laws that all people follow them. There is no like, there's a specific things that need to be followed, rules. And then there is a democratic leadership style, where decision-making is shared with members of a group, from the name. And then there's passenger. There's, in this one, they set high goals and standards, and then the team member should kind of try to keep up with those standards. So it's kind of push the team to kind of do their maximum. Then there is a transformational leadership style, in which the leader inspires and motivates employees to produce a change in the organization. It's mainly like by inspiration. And then transactional leadership is a style of leadership in which punishment and incentive are used. So you kind of motivate the team members by punishment or incentive. So you give them the credit, and they get blamed if they did something wrong. So some people like to have this style, but it depends. So any inputs about those styles, or someone think that he liked one style over the others, or think that maybe more success? I know that there's different situations that need different styles, definitely. But if anyone had inputs, you're welcome. There were a question about the styles. I hope I covered them well, or if you have any further question, you can go ahead. Okay, so we'll go ahead about leadership challenges. Leadership is not an easy, definitely. It's full of challenges. And one of the main things, the challenges actually the leader face, is the limited time, the team members themselves, and then the power. So the good leader should deal with all these problems. We have examples here of challenges. I divided them to external challenges and internal challenges. The external challenges, like insufficient resources, shortage of funding, employee objection and resistance, social issues among employees and distracted employees, and layoff and job replacement, maybe dissatisfaction of the employees because of the payment or because of the working hours, or all that. Then the internal challenges will be in the leader himself, like fear, lack of self-confidence, impatience, or anger. This is an important thing, that controlling your anger and your temper is an important factor when you communicate with your team members. It's definitely respect, as I said earlier, is very important and essential. How to overcome those challenges? It's communicating with the team, having open communication, seeing what their problem, receiving feedback, as someone said earlier, listening. Definitely a good leader is not the one who come to the meeting and say, okay, we have a problem, blah, 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 and I think like this is this. And does anyone have any input or ideas? You should first listen. You tell your team that we have this problem. So you listen to them. Actually, this will help your team actually to feel like valued and heard. It has many benefits, but it makes them feel, rather than just you're saying your idea and then you doesn't listen to their ideas actually, and you end up actually doing what do you think is right. But by open listening, you actually listen to them, and then you are, at the end, you're the one who would take all what they said and then improve your idea or maybe change it and then deliver what you think as a leader should be done. Being flexible and adaptable is important. Showing compassion toward work, toward team members is important as well. So all this would help the leader to overcome the challenges as the internal and external challenges. Leading with purpose is actually making the team worker motivate them and making them looking forward to be working with you and working harder. Developing priorities is an important as well, is important factor to overcome challenge. By if you're challenged by a lot of things, you have to prioritize what's actually important in the project and important to make the project successful. Providing stability is something important for the teams as well. If the company is firing people or changing the payment or whatever, if the team feels safe, they have their own responsibilities, they have their social responsibilities, health, education, and all that. So families, so providing them stability will definitely help to overcome leadership challenges. So we come here to Dr. Nader. Actually, leaders do not create followers, they create more leaders, and that's exactly what Dr. Nader is reflecting to us since we started this fellowship. I was really fascinated by how much organized, responsive, humble, and hard worker Dr. Nader. And it was actually a great great honor to be part of this and to have this experience from him. We've learned a lot, and I think it's we cannot speak about leadership without mentioning Dr. Nader. He's really a great leader, and I'm honored to know him and be part of this project. And thank you. So thank you, Dr. Nader. Thank you, everyone. If you have any question, go ahead.
Thank you, Sarah. Thank you, Sarah, and thank you, Kota, and everyone else. Thank you so much. You make my day. I mean, it's just you do your best. I think when it comes to leadership, there are a lot of things as you mentioned. But thank you, everyone. It's open for you if you want to add or have questions to Sarah. Please go ahead.
So I can't see anyone raising his hand. So we'll go to the next presentation. Is Dr. Abdelhadi is doing the introduction part of the Gastroenterology Presentation. If you're ready, Dr. Abdelhadi, go ahead. Oh, actually, Lubaba raised her hand. So go ahead, Lubaba first.
Good afternoon, everyone. Good evening. Sorry, I joined in and out. I am kind of busy. I apologize for that, but I came in the middle of the presentation for the leadership. I just want to say that was a great presentation, and I really raised my 10 fingers. And if there is more for adding Dr. Nader to the presentation, what you said is really, I believe, less than 50% about Dr. Nader. He is really following by examples and making great leadership. And I would like to use, I believe his name is Dr. Dave. In neurology grand round, he always asks the attendees to open their mic for a brief moment for giving a round of claps for Sarah and for bringing that last slide. If you can all do that, please. Unmute your, I don't think people are here. Maybe they're joining in and out as me, but I just want to salute you for bringing that slide, and I really appreciate that. That was a great presentation. Thank you.
Thank you, Lubaba. So, Dr. Abdelhadi, you are next.
Okay, hello, everyone. Good day. I am Abdelhadi Sayed, and I will do the first part, which was supposed to be before, but I had some troubles or some misunderstandings of the time of the session. But again, sorry, everyone. Let's take a look at the first part of the presentation of the gastrointestinal disease and disorders. So first of all, can you all see my shared screen?
Yes.
Yes.
Perfect. Now, at any time, if you do not hear me clearly, please let me know, okay? So let's see. The objectives of this presentation is to talk about the pathological condition that causes GI, symptoms and signs, and the labs and the imaging tests we use, and the treatment of choice, of course, for this and the natural history of this condition. Right? The endoscopy, which I think my colleague talked about earlier. So I will talk about the esophagus and its conditions, the stomach, and some of the colonic conditions. Okay. So the first disorder is dysphagia. And we divide this condition or this disorder into oropharyngeal and esophageal dysphagia. But first of all, dysphagia implies either the inability to initiate swallow or the sensation that food or solids or liquid get stuck in the middle of the swallowing process, like in the middle of the chest, and food cannot reach the stomach, right? So the oropharyngeal dysphagia, as the name implies, this is in the upper part. And for this condition, patients will complain of food getting stuck in the or inability to initiate swallowing. And yeah, for esophageal dysphagia, patients will usually point to their sternum when they ask to localize the site. Okay, and it's important to note that dysphagia in patients with dyspepsia will require immediate evaluation and therapy, as we will find out later on. Okay. So this is a picture of barium swallow in achalasia, which is one of the diagnostic methods. And it shows the famous bird beak sign. Okay. Continuing with dysphagia. So the first thing to do is to review the patient's medication. So some medications might reduce the salivary production, and this could contribute to the dysphagia. Such as the anticholinergics, antihistamines, or some antihypertensive agents. Okay, so the next thing we can do to diagnose this condition is endoscopy, which is the best first test, right? So it allows the biopsy and therapies, and it could help identify the lower esophageal sphincters or extrinsic esophageal compressions, or sorry, these the sphincters or the rings or the compressions might be overlooked in endoscopy, right? So we can alternatively we can use radiological evaluations or the esophageal motility studies if this is a functional obstruction. Okay, so yeah, we generally divide the causes of dysphagia into mechanical and functional. Functional means motility disorders, of course, and the mechanical means strictures or such conditions or such causes. So in this image here, this is an endoscopy showing a peptic stricture in the lower part of the esophagus. Continuing with the dysphagia, for patients with oropharyngeal dysphagia, we can do video colonoscopy, which allow us to take or to have a detailed analysis of the swallowing mechanics and identify whether aspiration is present, because this is a common complaint or common presentation with oropharyngeal dysphagia. And it can also evaluate the effects of different barium constituents. Okay, so the treatment of dysphagia will depend on the underlying cause. So one of the serious causes is esophageal cancer that will require, this condition will require the resections and chemotherapy, of course, or radiation therapy if the disease is localized. But if the disease has metastasized already, the other options can be the palliative chemotherapy. Okay. So another condition that could cause oropharyngeal dysphagia is the stroke or head or neck surgery, or degenerative neurological conditions, or so these conditions could benefit from swallowing rehabilitation and dietary modification to facilitate the oral intake, of course, that is required. So yeah, we can also use or do esophageal dilatation for patients with esophageal whips or strictures. These are some of the treatment modalities that we have. Next, let's talk about the gastroesophageal reflux disease or GERD. This condition is defined as chronic symptoms of mucosal damage produced by abnormal reflux of gastric contents into the esophagus. So highly specific symptoms for GERD will be heartburn and or regurgitation. This will occur often after meals. This will be aggravated by recumbency and relieved by antacid. So we found out that the incidence among people above 65 years and younger adults are somewhat the same. So causes of GERD are usually, or in 80% or more of patients, this is caused by transient inappropriate lower esophageal sphincter relaxation that can lead to acid reflux into the esophagus. Some patients might have reduced lower esophageal sphincter tone, which will again lead to the reflux of the gastric contents. Other causes such as sliding hiatal hernia could account for somewhat about 30% of patients above 50 years of age. And this might also contribute to the reflux of gastric contents causing GERD. So yeah, these are some of the causes. Let's move on to the evaluation of GERD. So the empiric treatment for this condition will be the acid suppression, which we'll talk about later on. But we can do upper endoscopy, and this is done if the empiric therapy is unsuccessful, or if symptoms such as dysphagia or bleedings or anemia, any of the alarm symptoms, if these are present, we usually do an endoscopy to see what's going on. Other diagnostic modalities could be a 24-hour ambulatory esophageal pH testing for patients with no esophagitis, right? And we could also do esophageal manometry for selected patients with whom we suspect esophageal motility disorders. Okay, so yeah, let's move on to talk about the treatment of GERD. Of course, the first choice is the proton pump inhibitors. And this therapy should be maintained for at least 8 weeks, followed by a trial of medications, right? But sometimes lifelong therapy might be needed, and the need for maintenance therapy may be determined by the rapidity of symptoms recurrence. Other treatment modalities, such as anti-reflux surgery and endoscopic anti-reflux procedures, are options for selected patients. For example, patients who requires lifelong therapy and who do not wish to continue with these medications for their life, right? And so there is one more thing to talk about regarding GERD. Some suggest that the induction of hypergastrinemia and gastric carcinoid tumors in rats treated with omeprazole has raised the safety concerns of this PPI medication. However, although patients treated with omeprazole for up to 5 years have shown gastritis and subgastric atrophy, there are no neoplastic changes seen with these medications, right? So, yeah, this was important to highlight as a complication of proton pump inhibitors or omeprazole, to be more specific. And now let's move on to talk about drug-induced esophageal injury. So patients will present with sudden odynophagia due to a degree that even swallowing saliva is difficult. So yeah, esophageal injury will present with odynophagia or painful swallowing, right? And this condition can be caused by drugs, and the common offenders are tetracyclines, or particularly doxycycline, or aspirin and other non-steroidals, potassium chloride, quinidine ions, or the famous bisphosphonate, right? So suspension of sacral fat coats the esophageal mucosa and promotes healing. So this is the treatment modality. And if possible, the discontinuation of the cosmetic medications or suspension or substitute a liquid preparation for this medication. Okay. So yeah, this is the esophageal injury with as a side effect of medication is thought to be because of decreased peristaltic clearance when the patient take the medication. It stays for a long time in the esophagus and could lead to esophageal injury. So we could, for example, with alendronate, with these patients should use these medications with cautiously. They should use it at least with 8 ounces of water. In addition, the patient should stand for at least 30 minutes and should not eat during these intervals. Idurtonate is an alternative bisphosphonate that is not been or has not been associated with esophageal injury. So this could be an alternative. Next, let's talk about esophageal cancer. So as you guys know, the esophageal cancer can be a complication of Barrett's esophagus right after GERD, or it can be squamous cell carcinoma. So this picture on the right side is showing Barrett's adenocarcinoma, right? And esophageal cancers are commonly diagnosed at an advanced, incurable stage, unfortunately, and in older patients who are not fit for tumor resection, okay? But we have endoscopic palliative therapies. This could be achieved by the stent placement or the laser therapy. And yeah, let's move on now to talk about dyspepsia. So dyspepsia is defined as a chronic or recurrent pain or discomfort in the upper abdomen. And one of the major causes are gastric or duodenal ulcers, GERD, or gastric cancers, right? So symptom pattern is inadequate for the diagnosis. Because symptoms like discomfort is very subjective and we cannot rely on that. So we have to do endoscopy for new onset patients with new onset dyspepsia, or patients with GI bleedings, or any of the alarm symptoms, right? However, endoscopy is normal in up to about 60% of patients. And these patients will be then classified as functional dyspepsia. So yeah, we will talk about the treatment modalities for these types of patients later on. But another causative agent is, of course, the H. pylori, could lead to gastric or duodenal ulcers. So in these patients, if you treat the H. pylori infection, this can heal the ulcer. Now the NSAID-induced upper GI complication. So the risk factors are patients who are 65 years of age or older, or who have comorbid medical conditions and who use oral glucocorticoids, or who has a history of peptic ulcer disease or use anticoagulants. So it's important to note that the risk of ulcers and their complications is 3 times greater in patients who use non-steroidals compared to other patients. And for those age 60 or above, the relative risk increases even more, up to 5-fold. And older patients, particularly women, are 2 to 4 times more likely than younger patients to be hospitalized with peptic ulcer disease. So yeah, we could say that the presence of H. pylori infection may have a synergistic effect on the NSAID-induced ulcer disease. Okay. So in these patients, in older patients, NSAID-induced ulcer disease can present with anemia, bleeding, or even perforation, or without the warning symptoms of dyspepsia or abdominal pain. So this is important to put in mind. And the concomitant use of the misoprostol or proton pump inhibitors may reduce the risk of GI bleeding. And for patients using non-steroidals, celecoxib may be a substitute in selected patients after careful cardiovascular risk assessment, and risk-benefit analysis. Now, moving on to talk about peptic ulcers disease. So, yeah, peptic ulcers disease in the United States is thought to be caused by H. pylori infection in about 80% of duodenal ulcers and 60% of gastric ulcers. So the symptoms of peptic ulcer disease, dyspepsia will be the most common symptom, but bleeding, anemia, or acute abdominal pain may also be presenting symptoms. These are some of the worrying symptoms. So when evaluating these patients, it is when possible, it's important to eliminate the drugs that can cause dyspepsia, such as NSAIDs, as we mentioned. But we should also order endoscopy to exclude malignancies if signs or symptoms, including the early satiety, weight loss, occult GI bleeding, or unexplained anemia. So any of the alarm symptoms, if present, we have to do endoscopy to see what's going on. And another alternative for the diagnosis of peptic ulcer disease can be made by upper GI radiography. Okay. Now moving on to talk about biliary disease. So biliary pain. This is when patients have an acute, severe upper abdominal pain, usually colicky, and usually located in the epigastrium or the right upper quadrant, and may last for about 1 hour, radiate to the back or the scapula, and often associated with restlessness, nausea, or vomiting. So yeah, the episodes might be separated by several weeks. So gallstones is the primary cause of biliary colic, coming from the gallbladder into obstructing the common bile duct, commonly leading to this biliary pain. So when these stones move further down into the duodenum, obstructing the ampulla, pancreatitis can also develop. So to diagnose these conditions, we use the ultrasonography as the first imaging modality. Then we can do a laparoscopic cholecystectomy, which is the procedure of choice if cholecystitis is detected in a patient with biliary pain. And this will not be indicated in patients with gallstones without biliary pain or any complications. Okay, so the possibility of gallbladder cancer should be entertained in any older patients with gallstones. And it is also important to highlight that computed abdominal tomography or CT scan may be used if common bile duct stone or ductal obstruction is suspected. And magnetic resonance cholangiography and endoscopic ultrasonography are also new accurate imaging modalities to detect common bile duct conditions like gallstones, for example. But however, in these patients or in patients with obstructive jaundice, cholangitis, or suspected biliary pancreatitis, where the probability of common bile duct stones is high, therapeutic endoscopic retrograde cholangiopancreatography or ERCP will be preferred. Okay. And that's all I have for the biliary diseases. Now let's move on to touch on constipation. So this is a fairly common condition, will affect about 30% of adults more than 65 years of age. And this will be defined as, stool frequency less than 3 motions per week. But some patients could also describe draining, defecation, or sensation of incomplete evacuation despite daily bowel movements. So the duration would not be less than 3 per week. So this is somewhat subjective, and the more objective diagnosis constipation is based on the colonic transit time, which is just the time the food takes to pass through the colon. So based on that, we can divide causes of constipation into normal transit time and slow transit constipation, disorders of rectal evacuations, including the pelvic floor dysfunctions. Okay, so let's talk about the constipation treatment based off what we have mentioned as causes. So first and foremost, patients with constipations, normal colonic transit time will benefit from fluids and dietary fibers, bulk laxatives such as psyllium seed, calcium, polycarbonate. Patients who respond poorly or do not tolerate fibers may require a laxative. Now, treatment of slow transit constipation will be the use of daily osmotic laxatives such as the sorbitol or lactulose, or lubipristone, which is a locally acting chloride channel activator that enhances the chloride-rich intestinal fluid secretion, so it can also reduce the symptoms of constipation. And the severe intractable colonic inertia with megacolon, this is somewhat a subtype of the slow transit constipation. This may require subtotal colectomy or even ileorectocolostomy. Okay, and the third type we talked about is the pelvic floor dysfunction or the disorders of fecal evacuation. So this can require biofeedback or relaxation exercises and suppositories. When talking about constipation, of course, it's important to talk about the fecal impaction because this could lead to constipation, right? For treatment of this condition, we should evacuate the colon with enemas or polyethylene glycol electrolyte solution until cleansing is complete. And we can prevent the recurrence with fiber-restricted diet and cleansing enemas used twice weekly, or a daily intake of 12 to 16 ounces of polyethylene glycol solution. Next, let's talk about the fecal incontinence. And this is defined as recurrent uncontrolled passage of fecal material for more than 1 month. And it affects 2 to 7% of elderly, mostly elderly people in poor general health. And this may be minor with inadvertent passage of flatus or soiling of underwear with liquid stool, or this can be measured with involuntary leakage of feces. And this really affects the quality of life. So this can lead to social isolation. Now, to diagnose this condition, we could use flexible sigmoidoscopy to exclude any inflammation or tumor. And the anorectal manometry can also be used, which measures the resting anal sphincter tone and the squeezing pressure, and rectoanal inhibitory reflex, the rectal sensation, and rectal compliance. And the rectal ultrasound can also be used, which can further evaluate the abnormalities of anal sphincters, the rectal wall, and puborectalis muscle. So yeah, before the lab test, of course, the history and physical examination could provide a clue to the cause of fecal incontinence. Okay, so for example, a defect in internal anal sphincter is associated with low resting pressure when we're talking about manometry, and defects in external anal sphincter can be associated with lower anal squeeze pressure, again, in rectal manometry. So the treatment of this condition is to reduce the stool frequency with antidiarrheals, such as loperamide, or improve the stool consistency with supplemental diet with bulking agents, and regular edification programs for patients with cognitive impairment or physical disabilities, right? The biofeedback to retrain the pelvic floor and abdominal wall musculature, the surgery if we need the sphincter repair or artificial sphincter, and also colostomy if patient has intractable symptoms. So the final topic that I have is diverticular disease. And this condition is prevalent in elderly people, like about 30% will have diverticular disease by the age 60 and 65% by the age 85. So diverticular disease is just outpouching of the mucosa and submucosa of the rectal wall or the colonic wall outside of the muscularis wall. So there will be herniations, and it's important to note that these are not true diverticular, right? So we do not see the 3 layers of the wall herniating outside. This is just the mucosa and the submucosa. Okay, so when these pouches develop, we will call that diverticular disease. If these pouches get inflamed, we will call that diverticulitis, and this is one of the common complications of diverticular disease or diverticulosis. So most of the patients will remain asymptomatic, but 20% will develop diverticulitis or inflammation of the diverticula, and 10% can develop diverticular bleeding. So those are the 2 common complications. So the mere presence of diverticulosis does not require specific therapy, right? Now let's talk about uncomplicated diverticulosis. So this can be an incidental finding on screening exams, and an example will be the image on this right side. So this is a sigmoid diverticulosis, and we can see the outpouches of the mucosa and submucosa into the outer muscular wall we talked about. Now, some patients can complain of non-specific abdominal cramping or bloating or flatulence or irregular bowel habits. But again, the presence of diverticulosis does not require treatment. However, one of the complications is diverticular bleeding, and this is painless and usually self-limiting. And this rarely coexists with diverticulosis or diverticulitis. The other complication is diverticulitis, and this usually presents with the left lower quadrant pain, so left side appendicitis, right? This is what they refer to it as. And this can also present with nausea, vomiting, constipation, diarrhea, or even dysuria, and urinary frequency, and we'll talk about those two symptoms as this condition can be complicated by fistulas, rectovascular fistulas. The fistulas develop, this can lead to the dysuria or urinary frequency or the presence of air within the urine, right? So other complications of diverticulitis can be like perforations and peritonitis. So during physical exam, you usually find the left lower quadrant tenderness, tender mass, and abdominal distension, right? So if you find generalized abdominal tenderness, this can mean peritonitis has developed as a complication of diverticulitis. And patients can also present with low-grade fever and leukocytosis, but these two tend to be absent in older patients. This does not exclude the diagnosis, right? So CT scanning is the optimal imaging method in acute diverticulitis. The CT scan features of acute diverticulitis include the increased density of soft tissues within the pericolic fat and colonic diverticula, colonic wall thickening, the soft tissue masses, and precolic fluid collection. So CT scan can also identify any peritonitis present or obstructions or fistula between the colon or the rectum and the bladder, the vagina, or the abdominal wall. So it's important also to note that in about 10% patients, diverticulitis cannot be distinguished from colonic cancer. This both can show slow focal thickening of the bowel wall. So in such cases, we have to do colonoscopy, but always note that colonoscopy is contraindicated in acute diverticulitis. So we have to wait and treat the diverticulitis first until the symptoms resolve, and then we have to do colonoscopy. Okay. So now let's talk about the treatment of mild diverticulitis. You have to give clear fluids and oral antibiotics such as ciprofloxacin, 500 milligrams BID, or metronidazole, 500 milligrams TID, or both, and hospitalization if needed if patients fail to improve. So once the symptoms resolve, solid food can be reintroduced and colon is evaluated, preferably by colonoscopy. Now the treatment of moderate to severe diverticulitis is to bowel rest and provide IV fluids and IV antibiotics against gram-negative rods and anaerobes, such as tifoxetine, pyroxylate azobactam, or gentamicin plus clindamycin. So if there is no improvement, diagnosis is incorrect or a complication is present, and such complications might be like abscess or peritonitis, fistulas, or obstructions. So the indications for surgery, if there is recurrence or intractable symptoms, or if there is the presence of a mass or obstruction or fistula or abscess formation, so any of the complication in addition to the intractable symptoms, right? So indications for emergency surgery will be peritonitis, obstruction, clinical deterioration or failure to improve, and abscesses that cannot be drained percutaneously. And that's all I have for this first part of the presentation. I hope everything is clear, and I hope that, yeah, if everything is clear, do you guys have any question?
Thank you so much, Dr. Abdelhadi. This is also great and concise and to the point. Excellent job. Thank you. Thank you so much for the.
Thank you, Dr. Nader, and thank you everyone for listening.
Thanks.
Thank you, Dr. Abdelhadi, for this informative presentation. Anyone has any question? I see the model. Okay, go ahead, Tamada.
Thank you, Dr. Abdelhadi, for this nice presentation. I have a question for Dr. Nader. If There is a patient with recurrent oral thrush, and he's not HIV or hepatitis, and this oral thrush prevent him from eating. Like every month, there is episode of oral thrush. So what, if you can guide me, what to do? Thank you.
Excellent. So, so thank you so much for the question. Thank you, Abdelhadi, for the great presentation. So in geriatric, we blame first thing medications. So for instance, in your case, the patient present with recurrent oral thrush. Are they on any medications that affect their immune system? Number one. Number two, are they taking any medications like antibiotics or so? That also will change the environment. Are they diabetic? Are they having any other conditions put them on this category where they are having trouble with this candidate? You mentioned they are not HIV, that one cause, but do they use, let's say, inhaler for asthma? Some of them will cause some problems the environment there. So mostly like Advair, if you use it, you want to wash your mouth after that. So there are a couple of questions that we need to ask the patient. If we cannot figure it out, any of these are not present, what their eating habits, what causing them to have problems, like do they eat certain foods that put them at a higher risk? So these are the things that I would ask. Treatment, usually we use oral solution. Most of the time it's helpful. Usually it takes a couple of days, 4 to 5 days or so. If it's recurrent, you can use diflucan, the oral tablet. Usually I give it maybe 100 milligrams once a day for 2 days, and it will take care of that. But again, you should think about the underlying cause, what put this patient at risk. I hope I answered your question. Thank you.
Yeah, thank you so much. Yeah, this is really helpful.
Any other questions? I do not see anyone raising his hand. I was just wondering, Dr. Nader, we have a presentation, Dr. Iman Ali and Dr. Selma Ali presenting their poster, if we should go ahead with that. Okay. So Dr. Selma and Dr. Iman, if you are ready, go ahead.
So again, for all present fellows, if you are involved in other activities or you have something to go after like 5-10 minutes now, that's fine. You can come back and look at the recording for the presenters, the person and her team. You can continue and don't bother yourself with the time. So we will continue until we finish what we need to do. Thank you.
Thank you.
Hi, everyone. I hope you're doing all well. Thank you, everyone, for your presentation. Sarah, you're an absolute amazing moderator. Thank you for that. So I'm going to share my screen. Are you able to see it?
Yes.
Yes, clear. Yeah.
So this is sort of, let's minimize this. This is sort of like the, well, somewhat final layout. But if anyone has any, input or advice, there are a couple of people out there, fellows, who have already presented. We'll be presenting this next week at Keck School of Medicine, and it's an elderly abuse symposium. So that's something to definitely be excited about. I don't know if I've discussed this with the other fellows, but I had a really hard time getting responses in terms of questionnaires. So it was basically divided into two parts. Ones were basically direct questions, demographics, what do you specialize in? And then there were open-ended questions at the very end where, providers were given a statement and, they had to say basically whether they agreed or disagreed.
Dr. Salma, can I just interrupt you?
Yeah,
can you present it the way you want to present, and then we will
sure
give you feedback, and unless you want to give background first for the fellows, and then we're gonna do your presentation there.
That's okay. We can definitely do that.
Thank you. I'm not rushing you, hopefully.
No, that's absolutely fine. So my title is an assessment of healthcare providers' preparedness and knowledge in managing elder abuse. My teammates are Dr. Nader, Hiba, and Sulapa. And basically, my background, mentioned a few points. The elderly are a vulnerable population. They require basically care from the community, healthcare providers, and assisted living facilities. Every year in the US, we have about 5 million elders presenting to their primary care providers or ED with some form of abuse. Out of the 5 million, only 1.4% actually report symptoms. Usually have providers being very diligent in screening or being proactive about picking up the various forms of abuse. We've got a bunch of screening tools in the literature. There isn't a set way of using one, or it depends on your hospital's protocol, your clinic's protocol, your personal preference. Some are patient-based, some are provider-based, some are mixed. And so part of the research should go basically on how they should be applied. And then further research should address why this issue is under-recognized and what can be done to improve reporting it. Objectives were determine if healthcare providers are adequately prepared to assist individuals experiencing elderly abuse, and whether the healthcare industry offers sufficient training on the topic or not. My inclusion criteria were healthcare providers working with patients over 65 in various specialties. It was 100 providers that were randomly selected, and there were active physicians in the US. I used a questionnaire. I used Google Forms to create it and also yield results. And then I shared it on LinkedIn and I emailed it to department heads. Hiba and Sulafa were very helpful in doing that. And then basically a bunch of results. The ones that you see here are most providers say, yes, they do have a protocol at their clinic in dealing with it, with elderly abuse. 20%, which is a very large percentage, said they weren't sure. Let's see. And then I think this is one of the most important results was, do you screen patients over the age of 65 for abuse in the absence of signs and symptoms? And 66% no. So I think this is like a target for future interventions. And then for the ones that have identified cases, what have you done? The majority have basically conducted a safety assessment. Others, referred patients or, but a very few percentage actually consulted APS. So basically, my conclusion or our conclusion was that despite evidence that providers are capable and knowledgeable of handling elderly abuse, there is a discrepancy between the numbers documented and the numbers reported by providers. We definitely need further research to determine whether educational interventions improve knowledge and attitudes of providers and whether they do or do not reduce the risk of abuse. And then we need to focus on multidisciplinary approach. And in the future, it may prove beneficial to conduct a quick and concise questionnaire during check-in to determine if the patient is feeling safe and whether signs of abuse are present. And then lastly, education, like targeted education resources to patients, because a lot of them don't actually know like the various forms of abuse. They think it's mostly physical, but there's like a bunch of others: neglect, financial, emotional abuse. And so they need to be made aware of their rights. And that way we can get more participation from them. These are my references, QR code, and yeah, Dr. Nader suggested that I print like a fuller version of my results and sort of hand them out if someone was interested in reading further. But yeah, that's all I have for now. Thank you. Any questions, additions, input?
It's 13 hours.
I see no one raising his hand. If anyone just have any questions or any, yeah, Lubaba, go ahead.
Yeah, I just want to comment to Selma's poster. It's really very nice, color-wise and readable, and the content's really new. I salute you for the research and the project as a whole. I guess you can add like acknowledgement for Michigan State University and the fellowship, and I think you need to add the disclosures too, so you don't have anything to disclose as part of the poster. The other thing, I like the way that you organized it, but if you can align the bullet points. First of all, you are presenting it online, right?
No, it's an in-person presentation.
Oh, okay, so you're gonna print it out. Okay, that makes a difference. Just don't worry about that then. Because I think in the poster, it would be, it will be obvious the point of that you're trying to make, kind of, it looks like a 3D or something like that. But I found, I was thinking that you're gonna present it online. The other thing, I'm not sure how long the attendees will be standing at your poster, but try your best to summarize as much as you can. For example, just talking about briefly about the background and make the objective and what you are trying to make out of this research big on the presentation. And regarding your method, just like say we did a questionnaire, we shared it with like many platforms, and avoid using I, say we did as a team. I know we tend to say that the stuff that we did ourselves, we will try to say like X and Z did this and I did this, but talk about as a team. And you can say Dr. Nader as our mentor rather than your, yeah, he's a team leader, but he's mentoring the project. This is from my opinion. But otherwise, it really looks great, and best of luck. Well done, excellent.
Thank you so much.
You're welcome.
I'll definitely get on it. And
yeah, it's really great work.
thank you.
Anyone have any input?
Perfect. I think.
So actually, I will give my opinion. I really like the the idea of the research actually about elderly abuse. And actually, I found that your objective was actually clear, and your result was actually reflecting what you wanted to study and your recommendation. So I see it as a very straightforward, clear study that will definitely make benefit for the readers and like people who are like taking decisions and making policies.
Thank you so much, Sarah and Luaba. I do agree with both of them. If you can put it back, the poster, Dr. Salman. And this is a really good job. I mean, you did great with the topic is important, and the layout and the presentation of the poster itself. You did good as far as selecting the colors and the font and everything. Let's go to the details. I like the way you set it up. The only thing I think you are still working on it, on getting lines aligned.
Yeah.
So you still make sure the boxes are not like the first box. The second thing, I know it's a rush for you, you just want to present for us, but think about what the reader, when they come to the audience, sometimes the contrast might be helpful, like you put here the acknowledgement, this work is supported by, you put the font black and the background is kind of dark, the same on the right side, the Michigan State. So either you take all these, put it at the bottom of the poster if you want to keep the black font, or change the font to yellow or white or something that's brighter, because the background is kind of dark. So at least for us in the virtual world, kind of a little bit dark on dark, it's not gonna stand out. So the rest, I think you did great as far as the presentation stuff. One thing I suggest, when you want to present, as Lubaba mentioned, be brief. People can read the details, but highlight the things that you found. Highlight the things that you think unique. So, for instance, you will mention, we found that, and then you talk about the first graph briefly, and maybe you touch on the second graph, but you will say, interestingly, we found that most people or most of the physicians in this sample did not or did something, and something like that. So you highlight with words like interestingly or something to grab the attention of the viewer or the audience. And then highlight what this means for you in the future, what you will do next. So this will basically build a station where you want to launch next project or next step or the education part. So these are the highlight for the audience to listen to you. So if you are enthusiastic in your presentation, these two parts that would grab the attention. Thank you.
Thank you so much.
So next, is there any updates about the projects you're working on, or if there anything you want to like speak about, just go ahead. So I can't see anyone raising his hand. So thank you, everyone. Thank you, Dr. Nader. Thank you for the presenters. And I know all are going about like through the stress of waiting the match results. So wish you all like good times waiting for the result, and have a good like weekend. Thank you.
Thank you so much, Dr. Sarah. And before we finish the meeting, I just want to make sure for next meeting, thank you, Dr. Mazen. I think you're going to lead the team or the meeting, switch with Dr. Sarah. I just put the name there. I want to confirm. The other thing is, these are the topics for the next team. If you want to switch names, please do so. And if you are able to communicate with the team members so that everyone is on the same page, that would be great. And I think Dr. Ala will present the work management poster next week. Thank you, everyone. And if nothing else, I wish you all the best.
Thank you, Dr.
Thank you so much.
Thank you all. Bye.
Thank you, Dr. Nader.
Thank you
so much.
Thank you.
Thank you all.
Assalamu alaikum.
Thank you.